Old Mr. Wallace was 76 years old when he first walked into my office, and I remember him to this day as if it were yesterday. A retired railroad worker, born and raised in Chattanooga, Tennessee, a man with big hands and a steady voice, who had spent his whole life hauling railroad ties and never spent a single day sick in bed. He came in because of a knee, that was all. A knee that creaked when he climbed the stairs, that swelled by the end of the day, that kept him from playing marbles with his great-grandchildren out in the yard. And an orthopedic surgeon had told him, with all the good intentions in the world, that the solution was simple. Replace the joint. A prosthetic. A routine surgery, the kind they do by the dozens every single day. Mr. Wallace walked out of that office with a date on the calendar and a relieved smile on his face. He figured he'd be chasing those great-grandkids around in no time. What he didn't know, what nobody had sat down to explain to him, was that the aching knee was the easiest problem he had, and that the surgery that seemed so simple was about to open a door he never imagined. I've been a physician for nearly 20 years, and in all that time I've walked alongside hundreds of people over 70 as they made decisions about going under the knife. And I need to tell you something right up front. Mr. Wallace's story stayed with me deeply, because it changed the way I talk to my older patients about surgery. Stick with me to the end, because I'm going to reveal to you the 6 operations that I, personally, would think long and hard about before agreeing to after the age of 70. And the 6th one, the last on the list, is the one most people accept with their eyes closed, without asking a single question. But before I tell you what happened to Mr. Wallace, I need you to understand something almost nobody explains. The body of a 70-year-old is not the body of a 40-year-old with more wrinkles. It's a different body on the inside. Think of the body like an old house, the kind built decades ago. Solid, beautiful, a home that sheltered an entire family. The structure is standing, the rooms still work, but the plumbing can't handle the same pressure it used to. The wiring heats up faster, and any major renovation runs the risk of disturbing a beam nobody knew was weak. The aging body is exactly like that. On the outside, sturdy. On the inside, with much narrower margins of safety. And here's the point that medicine sometimes forgets to say out loud. Most people think the great risk of surgery is the surgery itself. The cut, the bleeding, the heart stopping on the table. But it doesn't quite work that way. The numbers tell a different story. In planned operations scheduled calmly, mortality in older adults is relatively low, around 8 in every 100 among the very elderly. But when the operation is an emergency, done in a rush, with no time to prepare the body, that number can spike and climb close to 35 in every 100. Notice that detail, because it's going to matter. What kills isn't just the knife. It's the rush. It's the hidden frailty. It's what comes afterward. And what comes afterward is what nobody tells you. There's something called post-operative delirium. I know the name sounds clinical and cold, so let me put it in plain English. It's when an older person, who walked into the hospital lucid, talking, recognizing their own children, comes out of surgery confused, agitated, not knowing where they are, sometimes seeing things that aren't there. It's as if the anesthesia and the trauma of surgery had tampered with the wiring of that old house, and the lights started flickering out of control. And look at the scale of this. Studies of older surgical patients show this confusion can appear in a large fraction of them, in some settings reaching more than half of those operated on. Half of them. Think about that. And here's what's worse. A lot of people assume it passes quickly, that it's just the anesthesia wearing off. For many, yes, it improves within days, but for some, that confusion leaves a mark. Research shows postoperative delirium is associated with longer hospital stays, loss of independence, and in some cases a cognitive decline that can last for years. A person goes in to fix a knee and comes out with a different memory. That is exactly what was circling around Mr. Wallace. Now I need to ask you for one thing before I continue. If what we've covered so far is helping you see something you'd never stop to think about, hit that like button right now. It's a simple gesture. It takes a second, but it helps this video reach more sons and daughters who are deciding about surgery for an aging father or mother at this very moment. And if you haven't subscribed to the channel yet, go ahead and do that and turn on notifications. And tell me in the comments which city you're watching from. I genuinely love knowing where this conversation of ours is reaching. Now let me take you back to Mr. Wallace and to the 6 operations. The first on my list is purely cosmetic surgery on a large scale. And here I need to be very honest with you, because my commitment is to the truth, not to pleasing anyone. I have nothing against vanity. Wanting to feel good about your own image is legitimate at any age. The problem isn't the desire, it's the math of the risk. An extensive cosmetic procedure after 70, the long kind that takes hours on the table, with major skin lifting and blood loss, exposes a body of narrow margins to a risk it didn't need to take. Because this is not a surgery that saves a life. It's a surgery that improves an appearance. And when the benefit is cosmetic and the risk is your life, the scale, for me, tips heavily to one side. A long time under anesthesia is one of the factors most associated with complications in older adults. I would think very carefully. The second is major spine surgery done solely to relieve chronic pain. Pay attention, because this is one of the trickiest. A back that's been hurting for years is torture, I know, and the promise of a surgery that ends it is as seductive as anything out there. But the large spinal fusions, the ones that bolt several vertebrae together at once, are long procedures, with a lot of blood loss and a painful, drawn-out recovery. And here's the part that bothers me most. In many cases of chronic back pain, the studies show that the long-term outcome of these big operations isn't all that much better than more conservative treatments, like proper physical therapy and pain management. In other words, it's a high-stakes bet in a fragile body for a payoff that doesn't always come. I won't say never. I'll say, explore every alternative first. And it was right around here, at this point in the conversation, that a second patient came into my life, whom I have never forgotten. Mrs. Hancock, 73 years old, a retired seamstress, born in Asheville, North Carolina. A tiny woman with thick Coke bottle glasses, who raised 3 children on her own at a sewing machine, and still hemmed pants for the whole neighborhood for free. She came in wanting surgery for a herniated disc. She lived with pain, that's true. But when I went to look closely at her daily routine, I discovered something that changed everything. Mrs. Hancock was taking 5 different medications on her own, skipping meals, and had lost weight without noticing. She was in what we call frailty. And in plain English, frailty is when the body has lost so much reserve, so much muscle strength, so much margin, that it has nowhere left to draw the energy from to recover from a major blow. Operating on Mrs. Hancock in that state would be like asking a candle that's nearly burned out to hold steady against a strong wind. Look, I looked her in the eye and said, "Mrs. Hancock, before we think about your spine, we're going to take care of all of you." And that's what we did. And it's because of patients like her that I come to the third operation on my list. The third is elective surgery in patients who are already frail, with no preparation beforehand. And here's the point that science shouts today and that few people hear. The age on the document, the age on the calendar, matters less than we think. What truly matters is biological age, the real functional state of that body. There are 80-year-olds strong as an ox, and 70-year-olds who are already very frail. The studies are crystal clear. Frailty is one of the most decisive factors in a poor recovery, even more than age alone. So an operation that would be reasonable in a strong older adult turns into a game of Russian roulette in a frail one that nobody prepared beforehand. And that's exactly the mistake that hurts me most to see. Scheduling the knife without first building the patient up. The fourth is major abdominal or cardiac surgery done on an emergency basis that could have been avoided with proper follow-up. And here I come back to those numbers from the beginning, remember? The difference between operating calmly and operating in a rush, in an older adult, is the difference between a mortality of 8% and one that can border on 35%. That's a brutal difference. And what leads a person to need emergency surgery? Almost always, a problem that had been giving warnings for a long time and was ignored. A gallbladder that gave cramps and nobody investigated. A heart that gave signs and got brushed aside. That's why I insist so much with my older patients. Keeping a close watch, following up closely, is what keeps you out of the emergency room. The emergency room is where the aging body faces the greatest danger of all. But hold on, because now we get to the 2 that I consider the most delicate on the entire list. The 5th is major surgery recommended for a problem that probably would never have caused any symptoms in that person's lifetime. I know it sounds strange, but let me explain it slowly. It happens that we discover, on a routine exam, a small change, slow growing, the kind that would take maybe 15, 20 years to cause any real trouble. In a 40-year-old patient, it makes all the sense in the world to treat it. But in a body of 80-some years with other conditions, putting that person through an aggressive surgery, with all the risks of anesthesia, of delirium, of a difficult recovery, over something that might never have bothered them, then the math changes completely. Sometimes the wisest and most courageous treatment is to watch closely and not operate. And I know that goes against every instinct of, we've got to get that out right away. But real medicine is weighing what you gain against what you risk. Always. And now we reach the 6th, the last one. And it's the one I told you about way back at the beginning. The one most people accept without questioning. thinking it's the most natural thing in the world. The sixth operation I would think hard about accepting after 70 is any elective surgery where the doctor can't clearly answer one single question for me. And then what? What comes afterward? What's my recovery going to look like day by day? Who's going to take care of me at home? How long until I'm walking again, eating on my own, living my life? Because I've seen plenty of people come through surgery beautifully, the operation a technical masterpiece, the surgeon walking out of the room happy, and the patient never the same again. Not because of the knife, because of the afterward. The recovery nobody planned for, the bed that weakened the muscles, the confusion that didn't pass, the independence lost in a hospital bed. And this is where I have to confess to you the thing that hurts me most in these nearly 20 years of practice. It's not losing a patient in a difficult surgery, the kind we knew was risky. What truly hurts me is when a patient walks into the hospital on their own 2 feet for a procedure everyone called simple and leaves in a wheelchair, dependent, with a different look in their eyes. Because nobody stopped to ask, is it worth it? Can this body handle the afterward? That's what nearly happened to Mr. Wallace. Remember him? The railroad man with the aching knee. When I looked at his chart carefully, before that scheduled knee replacement, I saw the signs that the orthopedic surgeon, in the rush of his day, hadn't had the time to piece together. Mr. Wallace walked slowly, had lost weight, forgot where he put things, took a heart medication nobody had reviewed. He was a perfect candidate for delirium, for a difficult recovery, for the afterward to go wrong. And that knee, however much it hurt, was not going to take his life. So I did something that might seem strange for a doctor to do. I asked him to wait. I said, Mr. Wallace, before the surgery, we're going to spend 3 months building you up. We adjusted his medications, took care of his nutrition, got him walking and doing strength exercises with supervision, and treated a vision problem that was making him trip. 3 months later, the knee still hurt, but Mr. Wallace was a different man on the inside. And when we finally decided, together, calmly, to go ahead with the surgery, he went in strong. He came out well. And on one of his visits back to the office, he took me by the hand, with those eyes welling up, the eyes of a man who'd worked his whole life, and he said something I hold on to this day. Doc, you didn't just fix my knee, you gave me back whole. I'll admit I had to turn away for a moment that day. So let me give you a summary of what we talked about today, because it's important this stays with you. The question after 70 is almost never to operate or not to operate like that, in black and white. The question is something else. First, the greatest danger for an older adult isn't just the surgery itself. It's the emergency, and it's the afterward, the recovery, the delirium, the loss of independence. Second, the age on the calendar matters less than the real age of your body, your strength, your reserve. Third, major cosmetic surgery, a giant spinal fusion done just for pain, and aggressive operations for problems that would never cause symptoms, deserve very deep reflection. Fourth, close follow-up prevents the emergency, which is the most dangerous scenario of all. And fifth, the most important of all, never, ever, accept an elective surgery without your doctor clearly explaining the "and then what?" And I want to leave you with a reflection. The body that has reached 70, 80 years old is a body that deserves respect, not haste. It's like that old house that sheltered an entire lifetime. You don't tear it down to renovate over every little crack in the wall. You care for it tenderly, you reinforce the structure, and you only touch the beams when it's truly necessary and when it can be done safely. Deciding about a surgery at this age is neither cowardice nor stubbornness. It's wisdom, it's self-respect. And I ask you for one thing, from the bottom of my heart. Send this video right now to that stubborn father of yours who's going to schedule a surgery without asking a single question. To that mother who thinks she needs to have everything operated on at once. To that uncle, that grandmother, that elderly friend who has a surgery on the books, and nobody has sat down to talk with them properly about the risks and about the afterward. This conversation could be the difference between a peaceful recovery and a life changed forever. And in the next video, I'm going to tell you about something that connects directly to all of this. The 5 silent signs of frailty that show up in an older person's body long before any surgery. Signs that tell you whether that body is ready or not for a major effort. Most families ignore every one of them, and the third sign tends to get mistaken for just a normal part of aging, when it isn't. You won't want to miss it. Take care of the body of the ones you love the way you'd care for an old and cherished house, with respect, with patience, and by reinforcing the structure before touching any beam. Because inside that house lives an entire lifetime.